Thanks for being here today. Happy Friday to all of you. My name is Holly Brenner. I'm the Vice President of Strategic Development and Marketing for Agnesian HealthCare, and I appreciate that you're spending your morning with us. We'll go ahead and get started with a reflection and a little housekeeping, and then on to the main event. This reflection is entitled, Always Do Your Best. When you think it doesn't matter if you fail or pass the test, keep in mind the reason why you should always be your best. While the whole world may not notice if you tried to give your all, there is a person in you to whom it matters if you fall. That little voice inside you which directs your thoughts each day will make the final judgment if you won or lost that day. Never can you fail yourself if you give it all you've got. The world extends a hand to you when you give life your best shot. For all that really matters when you're finished with your test is not the final score at all, but did you do your best? All right, so we have with us Wapan and Ribbon on video camera. There's Nell's waving at me. So, and we have a few housekeeping things here in front of you. Next month, December 5th, mark your calendars for that. It'll be a great presentation. We did something similar last December where we had Steve Little come and Dr. Schmidt and Chrissy Bowl, one of our wellness coordinators, and Janelle Baldwin was here. You may remember her very exciting dance that she, maybe just mute it.
Put the mic down.
All right, we have the yellow comment cards. So I've told you in the past, and I continue to tell you, I take these very seriously, and we take your feedback to heart, make changes on the fly as we can, incorporate the topics that you've indicated are of interest to you in future presentations, so please continue to fill those out. I do appreciate them. And if you're interested in receiving a chance to win the Agnesian bag over here and accessories, please fill this out. And also if you're interested in receiving credit for being here, make sure to fill that out as well. So, and now I'll introduce our presenter today. Dr. Findling is here. Dr. Findling is an endocrinologist with Agnesian HealthCare. He's also a professor of medicine at the Medical College of Wisconsin. He went to medical school at the Northwestern University School of Medicine and is board certified in a number of things, including internal medicine, endocrinology, diabetes, and metabolism. He's also an international expert on clinical disorders of pituitary and adrenal function. So, without further ado, Dr. Findling.
Well, thank you, Holly. Good morning.
Good morning.
Good morning.
I didn't expect this big a crowd, to be honest with you. I've never done one of these before, so I wasn't exactly sure what I'm being asked to do. But before I start, I would just like to thank everyone in this Agnesian community in this hospital, St. Agnes, for how warmly Dr. Lalonde and my staff have been received. It's been really a nice experience for us over the last 18 months that we've been here. People have been very nice, the physicians, very accommodating. We're only here maybe 8 times a month, so we're not here maybe twice a week. So, but we've had a very nice welcome, and I've been very impressed with the quality of the care and the concern all of you have for your patients that we care for. So I've been very pleased, and we're hoping to expand our services somewhat starting next spring, so we'll be here maybe a little bit more often. I guess the goal here is to sort of give you a review of what endocrinology is about and what we do, or at least give you kind of an overview of what we do. And I'll probably specifically talk about the thing that I like to talk about the most, and that's Cushing's syndrome. The endocrine system is really complex, but in many ways elegantly simple. There are glands and organs that secrete proteins, hormones we call them, that are secreted from these glands and go somewhere else to do something else in the body. And maybe the most obvious example, of course, is insulin, which familiar with certainly all healthcare providers at this point. It's secreted from the pancreas, islet cells in the pancreas, that go to your muscle and liver to help store glucose. And of course, I don't need to tell this audience that deficiency of insulin from the pancreas or resistance to it because of obesity causes poor metabolism of glucose and obviously elevated blood levels, and that's diabetes. And problem that is currently epidemic in Fond du Lac County and every other county in America. This is obviously a major public health problem. So that's what endocrine does. It's a hormone, a protein-like insulin that goes somewhere else to do its work. And its regulation is often very complex. But there are many other endocrine organs. Let's see if I get the, yes, okay. For example, the pituitary gland, which is at the base of your brain, regulated by a part of the brain above it called the hypothalamus. But the pituitary gland is sort of often referred to as the master gland because it regulates several systems, primarily the thyroid, the adrenal gland, and the gonads. And because of that, it's often referred to as the master gland. It's very small, but it secretes hormones that regulate the thyroid, the adrenals, and the gonads. And of course, the thyroid disorders are very common. Probably, in fact, quite frankly, probably there are more people with thyroid disease than there are with diabetes. That's how common thyroid disease is. Thyroid disease is common all over the world. We'll talk a little bit about that in a minute. And near the thyroid, there are parathyroid glands that regulate calcium homeostasis. And if you, we laugh in our upstairs because I think there's something going on in Fond du Lac. There's an awful lot of people with parathyroid disease in Fond du Lac. I don't know whether it's just Fond du Lac or this is the sweep effect of us being here. The heart also actually makes hormones. The heart it makes hormones, it makes proteins that regulate salt balance in the kidneys. So it's also a hormone secreting organ. The adrenal glands, which we'll talk about more in a minute, which makes, of course, cortisone and adrenaline. The kidneys actually make hormones because they help to make the most biologically active form of vitamin D. So kidneys are also a hormone. They make hormones. The stomach makes hormones. Of course, the pancreas we talked about makes insulin and other hormones as well. And even the intestines make hormones. And of course, I don't need to tell you about the hormones that the ovaries and the testes make. That's what causes all the trouble in the world. These hormones, especially the one that the testes make, which is the source of all problems on Earth. They're right here. And since I have a predominantly female audience, I think you can all agree. Pretty easy, I think. I don't need to elaborate on that. Another part of the body that are affected by hormones that endocrinologists deal with are the bones, and I think this is actually a very active organ affected by many hormones. So endocrinologists do, among other specialists, deal with osteoporosis, and this is, of course, a major problem in older adults and women particularly women as they age, develop osteoporosis, and endocrinologists are often asked to diagnose and treat these kind of patients. And this gets back to calcium regulation. Again, the central part of calcium regulation are these glands, small glands in the neck. And of course, it's not uncommon, and I'm not exaggerating, see almost one patient a week in Fond du Lac with hyperparathyroidism. That's tumors in the parathyroid gland, which go to the bones and help and the GI tract and increase the absorption of calcium from the GI tract and the bones, raising the blood level of calcium. So calcium homeostasis is regulated by these four glands, very small near the thyroid. And tumors in these glands is extremely common and can cause osteoporosis, obviously, because it's taking calcium out of the bones. It can cause other problems, including kidney stones, because obviously this calcium's got to go somewhere. It eventually ends up in your kidneys. And also this hormone, parathyroid hormone, regulates the formation of vitamin D and calcium absorption. So calcium regulation is something that is dealt with by endocrinologists frequently. And I think there is either an epidemic of this problem in Fond du Lac, or I can't believe how many patients of this I see here.
So doctor, what do you think contributes, what can we contribute that to? Is it the nutrition? Is it?
I don't know. I think it's, well, most of us think it's just a sweep effect. In fact, if it continues on much longer, if it continues on for another couple of years, I'm going to have maybe the CDC to come in, because I can't believe how many. I mean, really, I mean, I don't know what our patient population base here is, but I'm not making this up. I see one patient a week with a parathyroid tumor. So I don't know if it has to, it may be, I don't know, there's some, we were laughing last night, we thought maybe there's some kind of radiation exposure, because radiation, clearly, low dose radiation increases the risk for hyperparathyroidism. For example, back in the 60s and 70s, I don't know so much in Fond du Lac, but in Chicago and Milwaukee, a lot of people got radiated to their tonsils and their bracing, even acne in the 70s. So that was, even into the 70s, I think that happened. Well, early 70s, maybe late 60s. And those patients, about 5% of them have developed parathyroid tumors. So low-grade radiation is clearly an effect it causes this. I think it's probably just a sweep effect. That is, a lot of these people have had this disorder for a long time. There's not been an endocrinologist here. The primary care physicians have not known what to do with the patients. Now that there's an endocrinologist, they send them. So most of these patients have had high calcium levels for 6, 7 years before we see them. And oftentimes this is an asymptomatic condition unless they have osteoporosis, of course, is an asymptomatic condition until you fall down and break your hip sometimes. So it's a good question. Right now we think it's just a sweep effect. I'm not sure that, but there is an awful lot of this here. I don't know. And of course, thyroid disease is common everywhere. It doesn't matter where you go. I mean, it affects hypothyroidism, underactive thyroid. 10 to 15% of women, certainly in the United States, all over the world, really. This is a very, very common problem. Often accompanied by a family history, and the treatment is thyroid hormone. In fact, I think there are more people on thyroid hormone than even insulin. I mean, thyroid hormone is, I think, the most commonly prescribed medication in the United States, if not, it's got to be one of the most commonly prescribed. I mean, as a chronic medication, I should say. I think more so than even insulin. I think there's more, I'm pretty sure there's more thyroid hormone prescriptions written than insulin prescriptions. Thankfully, thyroid hormone is not very expensive. Hyperthyroidism is also pretty common. 3% of women, it's not uncommon. 1 out of every 30, 40 women have hyperthyroidism, and of course many of these patients, because of the treatment, end up here. And these can be treated with medical therapy, radioactive iodine, and surgery. And these two disorders are, a big part of the practice that we have here, or any practice you have in endocrinology anywhere. It doesn't matter where you are, and even primary care. I think primary care physicians feel very comfortable managing most patients with hypothyroidism. I would say that's generally true. I mean, there's some nuances, like in every disorder, where you might need to see a specialist. Hyperthyroidism, in contrast, is something, because it's obviously less common, and primary care providers don't see it as much, probably should be referred to an endocrinologist, or at least somebody who's had a lot of experience treating hyperthyroidism. So I think all these patients really need to see an endocrinologist. These patients, I think, can be comfortably managed by primary care providers the majority of the time. There is, as you probably also know, an epidemic of nodular thyroid nodules. And these are common. Probably 50 to 60% of adults have nodules in their thyroid, but of these nodules, only about 6% are cancer. Now, there's just a fact that a lot of maybe the lay press, certainly in the medical literature this week and the last 2 weeks, about that thyroid cancer is the most rapidly growing cancer in, I think, the world, certainly in the United States by far. I mean, there's more people being diagnosed with thyroid cancer now. I mean, it may succeed breast cancer pretty soon. I mean, it's really common. But I think it's also pretty clear from a study that was just published recently from Korea where they're doing ultrasound screening in adults, that we're overdiagnosing this condition. Many of these cancers are small, they're indolent, and they're not particularly harmful. I mean, they're not going to kill the patient. Even if, I mean, as I tell patients with thyroid nodules that are quite small, I said, well, even if it's a cancer, you're not going to, even if we never take it out, you're probably not going to die from it. It's much like prostate cancer. I mean, a lot of prostate cancers are small and probably indolent and never going to kill anybody. The problem is deciding which ones are harmful and which ones aren't. And that's really the problem with thyroid cancer and thyroid nodules, is deciding which ones we should take out and remove. And now that we do fine needle aspiration of the thyroid, we can diagnose these pretty early, and if somebody has a very small thyroid cancer, I think it's always somewhat debatable what to do. It's very hard to tell somebody, well, you have a thyroid cancer, we're just going to leave it in there. It's like, I don't think people are going to, most patients aren't going to sit still for that. But I think we've also learned that we shouldn't over-treat it. I mean, just taking out the thyroid may, in many patients, be adequate. Some of them need radioactive iodine if they have a large cancer and if it's spread into lymph nodes. So thyroid nodules are common, and because they're so common and we use sensitive techniques like ultrasound to find them, we're finding a lot of thyroid cancer. Thyroid cancer is, again, a very common problem. And I think the issue is not that we're, I mean, it's got probably a 95 to 98% cure rate, something awfully high. But it's trying to figure out who those 2 to 5% of people who are not going to do well, who they are, and treat them aggressively at the beginning. So it's something we deal with commonly, and sometimes it's, I mean, patients understandably have a nodule in your leg, a lump anywhere. People are very concerned and they want to know what's going on. So fortunately, we have fine needle aspiration of the thyroid now to make that help that. Now I'm going to present some cases that I think are during the presentation that illustrate the importance of endocrine disorders in real life. This is a 66-year-old man who, in May of 1991, I didn't actually see this gentleman, but one of my friends did. He had syncope while he was jogging, and he was found to have atrial fibrillation. Now, it turned out his wife and his dog both had Graves' disease, which is a form of overactive thyroid. Now, thyroid disease is not sexually transmitted, and dogs don't give it to humans, so I think that's probably just a coincidence. But he was treated with digoxin and propiamide, as you can tell, a long time ago. I don't think they use this anymore. He had no response, and they were planning a cardioversion until 3 days later at a high thyroid level and a low TSH, which is indicative of a hyperthyroid state. And of course, one of the manifestations of hyperthyroidism is cardiovascular manifestations, rapid heart rate, and often, well, not often, but occasionally atrial fibrillation. And it's a treatable form of atrial fibrillation, so that all patients who have atrial fibrillation, new onset atrial fibrillation, always get thyroid studies obtained in this day and age. And this was the case that kind of brought this to light, because the patient happened to be a well-known American. So it's amazing that the most photographed, watched person on earth, the President of the United States, I would think you would probably, if you're going to say there's anybody whose days are chronicled on tape or film or whatever, more than the President, I don't know who it is. And maybe Justin Bieber, but I mean, and yet he was walking around hyperthyroid and no one knew it until he collapsed with atrial fibrillation. And it was 3 days later before the thyroid tests come back. Now, that was 1991, so it shows you what has happened. Now I think everybody realizes that even if the President of the United States can get a thyroid problem, and and nobody can see it, even though he's photographed and seen every day, that anybody could get it and not recognize it. So now, thyroid function studies, I mean, if I order a TSH this morning, I probably will after I'm done here on somebody, I mean, by the time I leave here today, the result will be back. I mean, probably in fact before I see the next patient, I'll be back. So thyroid studies are now done sort of routinely in patients, and the turnaround time is not 3 days, it's 3 hours. So I think that's what this case really, and that really was the case that kind of the seminal case that sort of changed our approach to thyroid disease. People realized all of a sudden that, my God, if the President of the United States could get a thyroid problem and nobody knows it, anyone else, almost anyone else could too. So, so we'll talk about the pituitary, which is one of my favorite subjects, and it regulates a lot of different organs. It secretes a hormone called antidiuretic hormone that regulates how much urine you make. That's in the posterior pituitary, what's called the posterior pituitary. Disorders of this are fairly uncommon. But again, it's the primary driver of the thyroid. This TSH, thyroid stimulating hormone, drives the thyroid to make thyroid hormone. And of course, TSH is the predominantly, and measurements of thyroid hormone are the predominant tests that are done. TSH is inversely related to the state of the thyroid. That is, if your thyroid levels are low, if your thyroid gland shuts off, this level goes up, trying to drive it to make more. So an elevated TSH means you have a low thyroid hormone. And a low TSH, like in President Bush, means you have too much thyroid coming out. And then more about ACTH, but ACTH is the hormone from the pituitary that drives the adrenal glands that are above the kidneys to make cortisol, cortisone. You've all heard of that. And we'll talk about the implications of cortisol in a minute. Growth hormone, we'll also see what happens when you have too much of this. Growth hormone stimulates the liver to make a protein called IGF-1 that stimulates growth. Now this is particularly important in children, not probably also important in adults. Growth hormone does have effects on energy, muscle mass, probably memory in some adults, sense of well-being, and of course it's a popular item being used by major league athletes because obviously it increases muscle mass. And of course now I think the NFL has just started screening, not exactly sure how they're doing it, screening the NFL players for the use of growth hormone. Or certainly I know Major League Baseball has started. I don't know if the NFL has started it yet. But this is a widely, I mean, there are 7 companies in the United States marketing growth hormone. 7. And I can count. And the number of medical indications for growth hormone are so small. So most of these people are selling, they're selling growth hormone, but they're not selling it to get people who need it, short kids or adults with low growth hormone levels. They're selling it to athletes. Prolactin is an important hormone in women because it stimulates their breasts to make milk after they have babies. Prolactin is otherwise has very little impact, but what tumors in the pituitary often make prolactin. And of course, again, back to the most important thing for survival of the species is that it makes gonadotropins, LH and FSH, to stimulate the gonads to make the things we need to continue on in life as a species. So it's, the pituitary gland, as you can see, is a pretty remarkable place for just a small organ. So endocrine diseases related to the pituitary is growth hormone, which too much you get very tall and you get to become a giant. That should be giant. Too little and you're short. So this is pretty straightforward. So this is important, particularly in adolescents. Too much ACTH stimulates your adrenal glands to make too many steroids, particularly cortisol, and that causes something called Cushing's syndrome, and we'll show you what that looks like. Weight gain, high blood pressure, diabetes, depression, weakness, and osteoporosis. This is a pretty common phenotype of patients. Not many of them have Cushing's, but some do. And an underproduction of these steroids, and underproduction of ACTH, or problems with the adrenal gland causes Addison's disease, which is weight loss, low blood pressure, low blood sugar, and weakness, sort of almost the opposite of Cushing's syndrome. That's Addison's disease. And this is a picture of a giant. This is one of my patients who actually from India. He's an engineer in Milwaukee. He works as an engineer in Milwaukee now. But he got very, very good care in India. I mean, he's 6'11", I think. 6'11", but which is pretty tall. And he's got very good care with pituitary surgery. He had a tumor in his pituitary making growth hormone that's called acromegaly, and in this case it's called gigantism when you get it when you're young, because if you develop this tumor when you're 12 years old, or when you're 10 or 11 years old, you get very tall. And a lot of people don't make the diagnosis right away because, oh, you're just tall, but then all of a sudden when you're 6'11" and your father's 5'6", and your mother's 5'2", people say, something wrong here. So, but he's the only giant I have currently in my practice. But it can be. This is the Alton giant. This is the tallest man he's from Alton, Illinois. Obviously, as you can see, it was a number of years ago. He died at age 22, but he was 8 feet 11 inches tall, and his shoe size was 37 AAA. 37, not 16, 37. And of course, this is obviously, you can tell many years ago. He was born, I think, in 1926, or maybe the 20s he was born, so this is probably the 40s. But in those days, they didn't know what this was. I mean, they didn't have pituitary surgery. They didn't have measurements of growth hormone. I mean, these giants were
and how did he die?
Not properly treated. I mean, you will never see this happen again. Well, not in maybe in a third world country, but not certainly not in the United States, because they'd be diagnosed a lot earlier and taken care of. But he was, I think, currently the tallest human.
How did he die?
He got an infection. He got some kind of, I think, infection actually in his foot or something. Again, you know, medical care. This is circa 1930 something. It's obviously not.
And what all of a sudden makes him stop growing then?
Well, eventually your epiphyses close. I mean, the reason you grow is your growth plates. I mean, you grow and then what makes you stop growing, if you know girls stop growing when as soon as they have their menstrual period, which is sometime in middle school, usually they stop growing. I mean, it's real. I mean, if you look at high school freshmen girls, they're the same height when they're seniors. I mean, go into a 7th or 8th grade graduation sometime. And these girls who look like young women, oh my God, you know, they're all dressed up, and these boys who look at it have no clue. Right? No clue. No clue. I mean, you all have kids. I mean, you know. I mean, they don't have a clue. I mean, whether boys ever have a clue, I have 3 of them. I'm not sure, but when they're in the 8th grade, they don't have, and they look like this little boys, and these girls are all grown up. Well, when they're seniors in high school, they look the same. I mean, they don't grow very much. In contrast, boys, of course, because puberty starts later, grow a lot between the time they're 14 and the time they're 18. So, so in a giant like this, I mean, what happens, the reason he grows is because he's got all this growth hormone, but his epiphyses, that is, his growth plates, aren't closing. And the reason they're not closing is because when you have this pituitary tumor, you can't make testosterone. Testosterone, or male hormone, just like in women it's female hormone, closes your epiphyses, your growth plates, so you stop growing. So boys, because the puberty starts later and they're still making hormones, they're in growth hormone, they're growing through high school. But as soon as girls start having their menstrual period, they're just about done growing. I mean, they might grow a little bit, but not very much. And so you'll grow and grow and grow until your growth plates stop, close. And so that's what makes him so tall, besides the growth hormone, of course. And just to give you my favorite part of the pituitary is the, of course, ACTH and cortisol, and we'll talk about a little bit about this. There's a hypothalamic hormone called CRH that stimulates your pituitary to make this ACTH to stimulate your adrenal glands to make cortisol. And my favorite description of this is from Kurt Vonnegut, who was a fellow Hoosier Breakfast of Champions in this book, 1973. My mindset and message to my hypothalamus told it to release the hormone CRF. This is now called CRH. into the short vessels connecting my hypothalamus, my pituitary gland, and the serum that inspired my pituitary gland to dump ACTH in my bloodstream. My pituitary had been making and storing ACTH for just such an occasion. Now, does anybody know, I don't know if some of you are old enough to have read this book, Breakfast of Champions. Does anybody know what the Breakfast of Champions was? It was a martini.
Oh.
Now, Nicole does not have any martinis for us. So I'm a little disappointed that there are no martinis for breakfast. But, so that's kind of good. And of course, this is a very complicated system. There's a circadian rhythm. Cortisol levels are high in the morning, late in the day, and there's a set point for feedback. I mean, like many endocrine systems, when this level goes up, it's supposed to shut off ACTH and decrease its secretion. So it's a very elegant system how endocrines, or when one system gets out of whack, when cortisol levels go up, it tends to shut off its production so you don't get too high cortisol levels. And the same way thyroid. So what I deal with is people who have either tumors that make ACTH in the pituitary, causing the adrenal glands to enlarge and too much cortisol. And sometimes these tumors can be in the lungs and the pancreas and a variety of other organs, and this is called Cushing's syndrome, of course. And people get weight gain, they get facial fullness and plethora. We'll show some pictures, increased fat in their supravicular, high blood pressure, diabetes, osteoporosis, muscle weakness, often depression, neuropsychiatric disorders, low gonadal function. Women often get hirsutism and extra facial hair and swelling in their ankles. So this is called Cushing's syndrome. And it can also occur because, not just for pituitary tumors, but adrenal tumors, and probably this is becoming the most, in fact, I just saw a guy yesterday that was referred to me for possible adrenal tumor, whether it's taking too much cortisol remains to be seen, but adrenal tumors, they can be multiple or just one, can make too much cortisol and cause a syndrome that looks pretty much the same. These are a little different because the cortisol excess is pretty intermittent and not very excessive sometimes, but they do have high blood pressure, diabetes, osteoporosis, and vertebral compression fractures. And these adrenal nodules can be around for many, many years. Sometimes this is referred to as subclinical Cushing's because these patients don't look like the classic patient with Cushing's. So adrenal Cushing's and pituitary Cushing's, adrenal Cushing's is pretty common actually. So when I see patients who are referred to me, I ask them to bring in old photographs to document. I mean, I see lots of people who have weight gain. I mean, the most prominent reason patients with Cushing's come to see me, or people think they might have Cushing's, is because of weight gain. I mean, we've all gained weight, so, I mean, but these are people who have sort of abnormal weight gain in a short period of time, and this is a young woman from Lake Geneva area who I saw. This is before her wedding, and this was about 3 years after her wedding, and her husband dumped her. I'm not sure what, and laughed, but that's probably why she's smiling. But he left her because she gained all this weight, and she had Cushing's syndrome, and after her pituitary tumor was removed, she went back looking like this, and has done well. Again, old photographs can be very helpful. It can occur in young people. This is a young lady with an adrenal tumor. And you can see sometimes that's why school photographs can be very helpful. And I often ask patients to go back very far to document their physical changes. Sometimes it's very hard when you see someone who's overweight and they say, I've gained a lot of weight. Well, show me some pictures. I mean, what did you look like 10 years ago? What did you look like 5 years ago? I mean, to document the physical changes. And of course, most people now just they can bring in this thing and flip through the photographs. And this was one of the very, very first patients I saw with Cushing's when I was in training in San Francisco. This is a woman with Cushing's, weight gain and diabetes, and this is after she had treatment 4 months later. You can see the dramatic changes. So we really change people's lives when we make this diagnosis. I actually have a photograph of her before she had Cushing's in this picture, but I can't show the before picture because she was Miss Penthouse in 1969, so I can't show that photograph. I used to be able to show it, but not anymore. And this is a woman who I still see 25 years later. She had, this is a photograph taken after she had a myocardial infarction, and she looked like she had Cushing's. And we'll see what she looked like after her adrenal tumor was removed. Changes people's lives. This is one of my favorite. I show this to people all over the world, but this is a guy from Columbus, Ohio, who got referred to me a number of years ago. His Cushing's was diagnosed by one of his friends. He's used to be a jogger. He was a runner, and he was at a cocktail party with his veterinarian friend with whom he used to run. Now, he stopped running because he got Cushing's, and when you get Cushing's, you gain weight, you're weak. I mean, you really can't, you just can't do what you used to do. So he's at this cocktail party, and his veterinarian friend, looks at him and says, "Jim, you know, why aren't you running with me? Well, why did you stop running?" And he starts elaborating his symptoms to his veterinarian friend. And the vet goes, "You sound like one of my dogs with Cushing's syndrome." And it turns out Cushing's syndrome is very common in dogs. And veterinarians think about this all the time because they see a lot of dogs with Cushing's. So Jim went to his primary care provider and said, "Gee, my vet friend thinks I look like a dog with Cushing's." And he was referred to an endocrinologist, and he had Cushing's. And it turned out he had a tumor in his lung that was making ACTH causing Cushing's, and we took it out.
Oh,
And,
wow.
he sent me this photograph a year later. So, yeah, it's pretty amazing. Changed
So
people's
all you had
lives.
to do is remove the tumor and it stopped?
And this is a woman who was sent to me a number of years ago from Philadelphia with obviously her husband and daughter with high blood pressure, diabetes, and she had a pituitary tumor we found and it's taken out.
Oh my goodness.
And this is her photograph a year later. So, of course, I have hundreds and hundreds of stories like this. So, we're going to switch gears a little bit about the adrenal gland. This is sort of, I think, the last slide, but this is, I'll give you another case presentation. This is definitely somebody I didn't see, you can tell by the year. This is a 30-year-old U.S. congressman. I like to deal with politicians, as you can see. Age 17, he was seen at the Mayo Clinic, which he called the goddamnedest hole I've ever seen. He had diarrhea, weight loss, he had a low sodium. That's a quote, that's an actual quote. I think he probably felt differently after you hear the story, but he collapsed in London in 1947 with low blood pressure and a low sodium level. And he was diagnosed in London as having Addison's disease, and he had 1 year to live, which was true because in 1947, cortisone had not been discovered. And so that's a true story. But the good news is that it was eventually discovered. And the oxycorticosteroid acetate, this was a steroid that was available. It's kind of called DOAC, and you get pellets on the skin every 3 months. It's a pretty weak steroid, but it was available in the late 40s before cortisone was discovered, and believe it or not, it was discovered at the Mayo Clinic. So the Mayo Clinic, like the goddamnedest hole in the world, Ed Kendall and Phil Hench won the Nobel Prize just a few years ago, I think in 51 or 52, for the discovery of cortisone. And in fact, this particular patient was actually archived in the archives of surgery. This patient had some back problems and had back surgery, and this was the first report of giving steroids when patients have Addison's disease, giving steroids to support their perioperative care, because if you have low cortisone and you go to surgery, if you don't get cortisone, you can die. So he was actually one of the first reports of that. And then in 1955, he had a low, at the time, which they didn't have thyroid tests, he had a low body metabolic rate, with hypothyroidism, and his younger sister developed Addison's disease. And in 1963, he died of a gunshot wound, and the postmortem showed no adrenal tissue. And of course, I think all of you know who this guy is. So if you're two presidents of the United States with endocrine problems, they're pretty common.
Do they have higher IQ?
I don't know. Thank you. So I'll be happy to answer any questions.
Can you totally take the pituitary gland out?
Pardon me?
Can you totally remove the...
Sure, you can take out the entire pituitary gland. We don't usually do that anymore. We take out the surgeons that operate on the neurosurgeons usually just take out the tumor and the abnormal tissue. It's really rare to do total pituitary removals in this day and age.
Because you'd have to.
I mean, it can be done, of course, but it's not.
And you can live.
And you can live because you can replace all the hormones. The cortisone, the thyroid, and the sex steroids can all be replaced easily. Now, it's not the same as having your own hormones. I mean, I think anybody who's been on hormone replacement therapy of any kind, whether it be thyroid, cortisone, or whatever, realizes it's not the same as your own body doing it. So your own body knows exactly how much cortisone you need at any moment, how much thyroid you need at any moment, how much female hormone or male hormone you need at any moment. And although we can replace that and prevent significant morbidity and even death, it's not the same. So we try to not disrupt the endocrine system unless we just have to. And sometimes we have to. Yes?
Is there anything you can do to boost your thyroid besides taking a pill?
Well, if you have thyroid disease, there's nothing you can intrinsically do to make your thyroid work better. People who take iodine, in fact, if you read some of the some of these naturopaths, people will give people iodine. Well, iodine actually is just counterproductive, it turns out, because I guarantee you that iodine deficiency is not a problem in the United States. One McDonald's hamburger, not that I'm suggesting you eat McDonald's hamburgers, has enough iodine for a month. Okay, that's all you need for 1 month. So there's bread and salt. Been iodine, there's iodine in all bread and salt now. So there is no iodine deficiency in the United States. Now there may be some areas that are lower in iodine than others, but there's no iodine deficiency. So giving extra iodine actually can shut off the thyroid, make it lower in some cases. And in people who have intrinsic thyroid disease, have a big goiter or something, and you give them iodine, you can make them overactive. So it seems like, well, paradoxical, but it's true. So taking extra iodine is really not helpful to the thyroid. In fact, it might even be counterproductive. In fact, one of the reasons, maybe, I don't think there's anybody here old enough to remember this, but back in the 50s, I have patients that tell me that they were given iodine tablets because if there was going to be a nuclear attack, let's say the Bay of Pigs, or I remember that in Cuba, that they wanted people to take iodine tablets, because what happens, in fact, when there is a nuclear reactor, like for example, and they didn't do this in Chernobyl, they should have, but if there's a nuclear accident, what they do is people have to take iodine tablets, because if you take iodine tablets, it prevents the radioactive iodine to get taken up in your thyroid, so it protects your thyroid by shutting your thyroid down. So iodine is actually a way to shut your thyroid down and not make it better. You don't need to take extra iodine. If you take too much, it just shuts it down. In some patients it makes it overactive, but it's not helpful. So there's no way to boost your thyroid, your own thyroid. If you have a thyroid disease that's been removed, or you've got a low thyroid, then you just have to take thyroid hormone. There's no other substitution for that. Yes?
And when you get your thyroid tested, they usually do the ordinary thyroid, and then there's something about TSH3 and TSH4.
You mean free T4 and free T3? Yeah.
Yeah.
TSH and sometimes we measure all of those things. It depends on the clinical situation. So TSH is a good test to determine whether you have a thyroid problem. If there's also some consideration of a pituitary problem, you do free T4 and free T3. Sometimes we do them all. I often do all of them. As a rule, I do all 2 or 3 of those, but not in every patient. It depends on the clinical situation. But you can measure the actual concentration of thyroid hormone, or you can measure TSH. And in many patients, we do both.
Often you read articles where it says your thyroid levels can be normal as far as a lab, but you can still have a thyroid problem. Is that true?
Well, normal is I think you have to be a little bit, understand what normal means. I mean, the problem is when you say normal, you have a test, and then they give you a range, okay, a range of normal. Okay. Now, for example, and this is a mistake that primary care providers make all the time. Let's say, let me give you an example. I don't know if you'll understand this. I'll try to make it as simple as I can. Let's say you have a pituitary problem, a pituitary tumor, some kind of pituitary issue. So what happens to your thyroid? Your TSH level goes down. It's low. Or it's normal. It may not be below normal, but it's low. It's not making much TSH because you got a pituitary problem. So what happens to your thyroid? Your thyroid shuts down too. And it becomes low. So if you measure the TSH and you think that's the thyroid test, and say the range is 0.4 to 4, and it comes back 0.6, that's in the normal range. 0.6, and a lot of physicians say, oh, you're normal. But if you've got a pituitary problem, and that's why it's 0.6, your T4 might be very, very low, and you might miss a low thyroid. So you can't interpret a blood test without a lot of other information. And so I think you have to be very careful about normal ranges in anything, and in hormones certainly the case. It has to be individualized from patient to patient. And the normal range of many things is very broad. That's one of the problems, is that there's a lot of very genetic, no, not some of it's genetically determined, but there's lots of variability in human biology. I mean, there's a wide range of normal. That's what makes life interesting. If we were all the same, it would be pretty boring. But we have a wide range of biological variation in normal people. Hormone levels, no exception. I mean, there's some things that are very tightly regulated in normal people, glucose being one of them, but many hormones have a wide range. If you don't know that, if you're a man and you're married to a woman, you kind of understand this wide range that occurs every month. Okay? There's a wide range of hormone levels within the course of a month, all right, that are normal. It doesn't seem like it's normal, but it's normal. So that's what makes life interesting, is this wide range. So when you see reference ranges and normal ranges, you have to take that, you can't take that out of the context of the patient. And I think that's what I think you're driving at. You have to look at the patient and understand what's going on with the patient to interpret. So sometimes things in the normal range turn out to be quite abnormal. So it depends on the entire clinical picture. Yes?
If you're taking medications for other ailments, are there specific medications out there that would have an adverse effect on the pituitary gland?
Well, sure. I mean, there are many things that can affect the pituitary gland. Drugs, if that's what you're talking about, that can have impacts. I mean, for example, I mean, that's what birth control pills do. I mean, birth control pills, obviously they went a tremendous breakthrough in the 1960s, I think, late 60s, are hormones, estrogen and progesterone, that shut the pituitary gland off, so you can't make eggs and female hormone. So that's what it was. I mean, birth control pills is the predominant affects the pituitary gland, shuts the pituitary gland down, not the entire pituitary, just the two hormones, LH and FSH, that stimulate the ovaries to make eggs and estrogen. So birth control pills, pretty commonly used. So that's probably one of the most, that directly affects the pituitary. That's what it does. It shuts off the pituitary. And there are other drugs, steroids, for example, when you get epidural steroids, when you get injections of steroids, take prednisone for asthma, whatever you do, that affects the pituitary. It shuts off the hormone ACTH, then shuts off your own cortisol. So why would your adrenal gland shut off? Because you were taking steroids. It doesn't have, you don't want to take more. Your adrenal glands don't want to make more under those circumstances, so they shut off. So it has a nice system of shutting off your own. Now sometimes that can be problematic, but a lot of drugs can affect the pituitary gland.
for these athletes that take these long-term growth hormones, their life in 20 years, will it be different because they've abused that drug?
Well, I mean, I don't, I mean, growth hormone in excess, I mean, for example, people who have, like the Alton Giant, but, I mean, there are people that have too much growth hormone, they have a high risk for cancer, so, many cancers. So, growth hormone stimulates cancer growth, so it may increase their risk for cancer. So, I think excessive amounts of growth hormone are probably not useful in any meaningful way. It's often used as these aging clinics. I mean, this is big in California and some parts of the United States. Probably not so big in Fond du Lac, but where you can go and you can live forever, and they give you testosterone if you're a man, or they give you growth hormone to try to keep you younger. I think there's no evidence that those things are safe or even very helpful. But it doesn't, Barry Bonds is probably a good example. I mean, it's clear that he took growth hormone. It probably took more than just growth hormone. He took testosterone. And hit 71 home runs, whatever year it was. But I mean, I'm sure his hormone milieu included growth hormone treatment. And if you look at him from the time he was playing for the Pittsburgh Pirates when he was just a young player, and the time he was playing for the San Francisco Giants, I mean, he's got this, he's a wholly different looking person. Now, some of that, I mean, obviously he's probably lifting weights and so forth, but he got a little help. He got some help.
Findling, how do you differentiate between the guy that comes in that drinks a 12-pack of Bud and 7 fish fries a day, and the person that really has some type of thyroid?
Yeah, it's not. Well, it's a very, very good question. It's a question because the phenotype looks pretty much the same. I mean, you can't. I mean, just looking at the patient, you can't tell. So I give people the benefit of the doubt, and what we do is we do hormonal testing if there's any index of suspicion. Because in this day and age, these hormone levels and measuring them is pretty simple. It's not complicated. I mean, a blood test, something we do tests in like cortisol we do in the saliva. I mean, they're simple to do. They're not terribly expensive. So I give people the benefit of the doubt and screen people with a pretty low index of suspicion, particularly thyroid, which is really cheap. So these tests are not expensive, readily available in almost anywhere, and so it doesn't take much for me to pull the trigger. Now I have noticed there are a lot of people in Fond du Lac that do drink a lot of beer
and eat a lot of bad food.
And eat a lot of bad. In fact, I have to I'm going to make a trip to Blank Supper Club. I got to make a trip there. It sounds really good. And
don't go there.
So, maybe Agnesian will pay it. I guess. But yeah, there's a lot of beer and a lot of beer that people drink here. But it's everywhere. It's everywhere. I'm kidding. It's like not just in Fond du Lac. It's all over. Thank you very much.